Yeah, thank you for the kind invitation. And to all of you who have taken time to attend the webinar, I just hope that you find the presentation useful. When the organizers had asked me what topic that I'd like to do, we had discussed and then we decided that we'll do one talk on local and regional flaps of the head neck, and then do one talk on free flaps in the head neck. So this presentation is about the local and regional flaps that we commonly use in the head neck. Where do you make the choice of what flap to use and how you make that choice? And are there any particular things that you have to keep in mind when you think of the execution of such flaps? Now, the goals of this presentation is to describe the commonly used local and pedicle flaps in head and neck reconstruction. And mostly it will be in the context of clinical scenarios. So I've divided the talk into cervical skin reconstruction, cheek reconstruction, tongue reconstruction, and so on and so forth. And in each of these scenarios, you'd see what local and what pedicle flaps we can use. And then each flap obviously has its own advantage and disadvantage, and we have to be well aware of the pitfalls of some of these flaps so that we don't overdo flaps and end up with failure of these pedicle and local flaps. I'm not showing any videos today because I think some of you have seen my channel on YouTube. The videos are there of all flap harvests and resections. It's free to view, and I would strongly encourage you to have a look at the site. It's called Learn Head Neck Surgery, and most of the pedicle and free flap harvest is described in detail. So I urge all of you to have a look at that site so that you get an idea of the steps of flap harvest. Now, as you all know, reconstruction is a critical aspect of modern head neck surgery. If you look at the data that we have, which has looked at the temporal trends of how people who've had head neck cancers have benefited and been cured, we are able to do more extensive resections. We are able to do more extensive tumor removals, which have resulted in bigger defects. And with the help of reconstruction, we are able to close these defects. So, in a sense, we are enabling larger resections without compromise. And obviously, reconstruction is essential for form and function. If you don't reconstruct the form, you're not going to be able to get functional outcomes. And without functional outcomes, the patient is a cripple. And we have moved from just closing a hole to try and do functional restoration in a lot of these cases. But as we do more and more flaps, we are coming to understand the morbidities of reconstruction also. For example, if you harvest a DCIA from the iliac bone, you know that there are going to be functional problems after the harvest. So the more flaps we do, the more we realize that the secondary morbidity from the flaps should also be taken into consideration. And there's always an eternal debate between free versus pedicle flaps. In my book, most of the reconstructions can be elegantly done with pedicle flaps. Free flaps need not be the answer for all defects. Probably the only area where free flaps are better is in the scenario of bony reconstruction of the mandible and maxilla, where we still don't have a reliable pedicle bone flap. But in all other instances, a pedicle flap does most of the things that a free flap is supposed to do. So the problem that we commonly encounter is that our defect is usually a three-dimensional defect, but we measure it in terms of two-dimensional sizes, and then we try to recreate the tissue that we have lost. And we always have to consider whether we need cutaneous versus mucosal versus full thickness reconstruction. We have to plan whether we're going to recruit local tissue or we're going to recruit distal tissue. The site of the defect also plays a role in deciding the type of flap that you're going to use. So intraoral versus extraoral defect. And whatever the flap that you have planned to harvest, remember one very important aspect. If you have tension at wound closure, the flap will dehisce, and you're going to end up with a lot of problems because pedicle flaps have a tendency to move with gravity. They tend to sag, and you're going to end up with a dehisced suture line, which is going to be very difficult to manage. So, and then torsion. because you're not dividing the pedicle as a free flap, you don't get that much freedom of moving a pedicle flap. So avoid tension or torsion during closure, and that is very important to consider when you're thinking of pedicle flaps. Now, flaps can be defined by the type of tissue that they provide. So you can have muscle flaps, adiposal flaps, you can have just a skin flap, or you can have a mucosal flap. Now, this is something that you keep in mind if you want to, for example, if you want to do a tongue reconstruction or a cheek reconstruction, you would like the area to be resurfaced with mucosa if it is possible. So, trying to replace like with like is important, but even pedicle flaps do offer you different types and different choices when you try and harvest the flap. Now, what are the advantages of doing a pedicle flap or a non-microvascular flap? The flaps are very robust. There is no microvascular anastomosis required, and most of these flaps have been in and around for the last 40 years, so they have withstood the test of time. It is relatively easier to harvest than a free flap. If harvested well and if tissue anatomy is respected, there can be minimum donor site morbidity. These flaps are especially useful in patients who are debilitated and those who can tolerate only short anesthesia. And I would think that the best indication for a pedicle flap is when you're planning for salvage surgery, where you know that a free flap might be difficult to anastomose because there is vessel depletion in the neck, or the tissue is scarred and you might not be able to elevate tissue planes. In those cases, the pedicle flaps are probably more useful than free flaps. Now, the disadvantages are that you just cannot take pedicle flaps to cover all the areas of the head.
It's not messy. It's very messy because dental do not speaking to medical.
No,
Sorry,
it's just
somebody said something.
So please carry on, sir. I think it's just they have unmuted accidentally.
Okay. So the disadvantage, as I started, is the reach and arc of rotation. That is a problem with all pedicle flaps, is that the reach is not, to certain areas in the head neck, the reach is just not there. The free flap, if you raise an ALT or a radial forearm, you can take it anywhere in the neck because you're not constrained by the pedicle holding the flap back. So the reach and arc of rotation can be a problem, can be a disadvantage in certain instances. Then sometimes it's difficult to contour the flap for thickness, especially if you have a bulky pec major. It might be difficult for you to contour the flap because you don't want to defatten a pec major too much and damage the perforators that are arising through the muscle. So you might have problems with flap bulk, especially in patients who have very good body habitus. There's no reliable bone pedicle flap as yet, as I mentioned earlier. And some flaps, if you expect too much from a flap, for example, if you take a flap beyond its angiosome, beyond the second angiosome, I will tell you what the angiosome concept is in the next couple of slides. If you try to overextend the length of a flap, then the distal vascularity of the flap may be a problem. And we all know that the distal area is what is going to go into the. And if the distal part of the flap necrosis, imagine if you're doing a pharyngeal reconstruction or you're doing a buccal reconstruction, and if the distal part of the flap necrosis, then there is a problem. So some of these flaps may require delay, wherein you open the choke vessels and you ensure the vascularity of the distal part of the flap, especially in the deltopectoral flap. And this might delay your surgery or add another surgery to the patient's surgical treatment. So good scenarios for local pedicle flaps is cheek defects, eyelid medial canthal defects, lip defects, nasal dorsal defects, buccal mucosa defects, tongue defects, and pharyngeal defects. Now, the reconstructive goals are different for different sites. For example, in the tongue, you have to ensure mobility is restored. You have to make sure that the mucosal cover is replaced either by mucosa or by skin. If the resection involves the floor of mouth and the mylohyoid muscle, you have to ensure orocervical separation. And if you're doing large tongue resections, you need to recreate the bulk of the tongue that has been lost. Buccal mucosa, again, mucosal cover either by skin. And then if the defect is through and through, you need external skin as well. If there is a floor of mouth defect, again, you need mucosal cover. You have to make sure that the tongue doesn't get tethered to the floor of mouth, and you have to ensure orocervical separation. The lip, the requirements are volume of the lip, the sling, the muscular sling of the lip, and commissure competence. Pharynx, you have to reconstruct the foot conduit to connect the oropharynx with the esophagus. Palate is oronasal separation and orosinus separation. And in the mandible, you have to ensure bony continuity, form, and occlusion. So as I mentioned, majority of these goals can be met with well-selected local and regional flaps, and barring the mandible, the pectoralis major or the supraclavicular or one of the flaps can be easily used to attain good closures and good functional outcomes. This is the table that I've taken from a very old textbook. This is the Principles of Plastic Surgery by Gillies and Millard. And they had said this in 1957. So you should always treat the primary defect first. This is a very important line. Borrow from Peter to pay Paul only when Peter can afford it. Meaning, whenever you harvest a pedicle flap, make sure that the pedicle flap can donate tissue, or the donor site can donate vascular tissue. Don't overdo pedicle flaps and end with distal necrosis or donor site problems. So careful assessment of the flap, careful assessment of the donor site, the assessment of the limits of the flap and what it can contribute. All of these are important before you jump in and start doing a pedicle flap. So in today's era, I think the pectoralis major is the most common pedicle flap that we use. DP flap has sort of moved away in the ladder. Supraclavicular flap is probably what a lot of people are doing these days. It's becoming more and more popular. The latissimus dorsi is another good flap, but because of the pectoralis major's popularity, not many people do latissimus. I haven't done latissimus in a very long time because the pectoralis major basically takes care of most of the defects. So the advantages of the pectoralis major is that it's got a large skin paddle. It's very robust. It can cover a wide range of defects in the head and neck. It's relatively easy to harvest with minimal donor site morbidity, and it's a good salvage flap option. The deltopectoral flap is got a smaller skin paddle compared to the pectoralis. The distal vascularity, especially when you cross the deltopectoral groove into the third angiosome, is a problem. The advantages are that the skin is very thin and relatively hairless, but you're again constrained by the reach because it's got an anomalous arc of rotation. You need to skin graft the donor site, especially if you go over the shoulder. It needs flap division at the end of the 3 or 4 weeks after it's been inset. And if you want to ensure distal vascularity, you may need to delay the flap. The supraclavicular flap has an intermediate skin paddle availability between the DP and the pectoralis, good vascularity. I would say the reach is slightly better than the DP flap, but still intermediate reach. The donor site can be closed primarily, and it's usually thin, hairless skin. LD has the same profile as that of the pectoralis major, large skin paddle, robust, but you need patient repositioning. It can reach quite easily up to the ear for auricular defects, and you have to be careful about the tunneling, especially when the pectoralis major is still intact. Now, you have to understand vascular anatomy of tissue and skin before you start harvesting these flaps. And everyone has followed the reconstructive ladder, and now we are in the era of free flaps, but local flaps are just below that. We don't follow any of the other types of healing for head and neck because you need to get the fistulae and the defects closed because the patients may need to go for radiation or the patients may need to resume an oral diet. So even in the reconstructive ladder, I think the local tissue transfer and free tissue transfer are still very good options. So one of the common things that we encounter are cheek defects. Now, cheek defects can be small, medium, large, or they can be enormous defects. Usually the cheek, we don't see cutaneous cheek defects that much, but I would just briefly touch upon what flap options we have for cutaneous cheek defects. But then we'll try and focus our attention more on the medium and large through and through defects. I would suggest all of you to read this excellent article by G.D. Lister. It's available freely on the internet, hosted by one of the colleges from North America. He describes elegantly how to do a Limburg flap. Now, it's very easy to create an ellipsoidal defect. You resect the tumor, you make the defect an ellipse, and then you try and suture that ellipse. That is what normal suturing practice dictates. But the longer the ellipse gets, the more difficult it is to get the tissue into approximation. So a Limburg flap is a very elegant solution for reconstructing small defects of the cheek. Basically, you're converting the ellipse from curved lines to a straight line. And for each Limburg or each rhomboidal defect, you can mark 4 Limburg flaps. So here, if you look at this picture, the defect is TSXU, and then you mark out a Limburg flap, which is U, V, and W, UV being the same length as the short axis of S and U. And once you elevate the flap, you can inset it into this defect. Now, this is very good for small defects, and it's a lot by trial and error that you learn how to mark a proper Limburg flap. So I would suggest that all of you download this article and read for cutaneous defects by G.D. Lister, and he has very elegantly mentioned how to even use multiple Limburgs to close a defect, or by Limburgs from both sides to close a large defect. So a Limburg flap is something that you should know prior to starting doing cutaneous malignancy work. Now, if you look at cheek defects, in the next slide we'll show you that. I'll probably come back to this slide again. If you look at cheek defects, there are 3 zones of cheek defects. The first zone is the infraorbital zone. The second zone is the preauricular zone. And the third zone is the gingivo-alveolar zone or alveolar buccal zone. Now, if you have defects in the infraorbital zone, it is always better to try and do a Limburg flap, or you can do one of the cervicofacial rotation advancement flaps. But if you have a defect, that is for defect zones 1 and 2, you can do that. If you have a defect in zone 3, it is quite difficult to do a cervicofacial rotation. So this is nothing but a VY advancement. So you had a cutaneous defect in zone 3. And you can do a simple VY advancement and close the defect, or you can use the DP flap or the supraclavicular flap. But if you have a patient who's got lax skin and you're able to recruit tissue from the adjacent side, you can just try to do a VY advancement. So this is another free article that I suggest all of you download and read. Not all cutaneous defects need distal recruitment, like for example, a DP flap or a supraclavicular flap or a pectoralis major flap. You can make use of the cervical skin, and you can use a cervicofacial rotation flap to close the defects in zone 1 and zone 2. So here you see the picture. There's a sequence of pictures. This is the first picture, shows you what the zones are: zone 1, zone 2, and zone 3. And this is how you mark out the flap that has to be elevated. Now the incision, this can be copied verbatim textbook when you see a defect. You don't have to think too much. The flap of skin that is elevated is usually done in the supraspinatus mass and subplatysmal layer, so that you avoid damage to the facial nerve and its branches, and you improve the vascularity of the flap by capturing the facial artery perforator. So the first picture shows a small defect in the infraorbital area, which is closed by a cervicofacial rotation. This is a preauricular defect, and this is a different design where the flap is curved slightly towards the mandible, and then you have a Y-shaped closure. And this is another picture where you have an inferiorly placed flap, which is based from the anterior vessels, which can be turned and sutured into the preauricular defect. So this article is by Bokhari, again from the States, It's a free article, and I would urge all of you to download and read the principles of a cervicofacial rotation flap if you want to do it for cutaneous defects. Now, there has been talk of something called the deep plane cervicofacial flap. Now, the deep plane cervicofacial flaps have been propagated by Sweet Anne from New Zealand. Basically, they are anteriorly based flaps. So, if you have a defect here preauricularly, or if you have a defect here infraorbitally, you try to preserve the perforators that are coming from the facial artery. And then you mark the skin flap, and then you rotate the skin flap into the defect, but the skin flap is raised so that the perforating branches from the facial artery are preserved. Again, these are textbook defects. You can look at the picture, mark it on a patient, and then you can do these flaps. But the deep plane cervicofacials are probably better because you're improving the vascularity by including the perforators that are coming from the facial artery. Now, coming back to the previous slide, sometimes people have gone up to the thoracic skin. So the cervicofacial rotation earlier used to be, you have to make the incision long enough to go into the deltopectoral area, and then only the skin paddle would move. But now we have moved away from extending into the thorax because most of the skin incisions can be limited to the cervical skin and the cheek skin, and these defects can be closed. So for defects in the zone 1 and zone 2, a deep plane cervicofacial flap is very useful to close these defects. And probably in our practice, we would see these defects from parotid malignancies which are involving the skin. Now, the commonest flap that we would use to close a larger cheek defect, for example, a through and through cheek defect, would be the pectoralis major flap. Now, I'd mentioned to you the pectoralis major flap has got a large skin area. You can virtually take skin from the entire chest based on the pectoralis major muscle. So you can either have a small muscle, a small skin paddle as here, or you can have a very long skin paddle as shown in the picture below. Now the blood supply of the pectoralis major is from the pectoral branches of the thoracoacromial artery. And these arteries usually enter the muscle quite high up, just below the clavicle. After piercing the pectoral fascia, they enter into the underside of the muscle, and then they, ramify within the muscle and supply musculocutaneous and faciocutaneous perforators to the skin. Now, the pec major can be tubed, can be bipaddle, can be deepitalized if you want to create two different surfaces. The donor site can be closed primarily in most instances, but whenever you plan to do a pectoralis major flap, just make sure you don't violate the DP territory. The DP territory is important because, if you have problems with the pectoralis major, if you have a marginal loss, or if you need to do a salvage flap, it's always useful to have the deltopectoral flap territory intact. Now, there's a lot of question on how far below that you can take the pectoralis, how far beyond the pectoralis major muscle that we can base the pectoralis flap on. See, you have to be reasonable. A length of 2 or 3 centimeters, once you go beyond the pectoralis major muscle, you're going to encounter the rectus sheath, and we take the rectus sheath along with the pectoralis major, the flap. If you look at the angiosomes that supply the pectoralis major muscle, the primary angiosome is from the pectoral branch of the thoracoacromial artery. The second angiosome is from the intercostal perforators of the internal mammary. And as you go further down, it's from the superior epigastric. Now, the superior epigastric perforators don't reliably supply, they're usually cut. When you obviously raise a very long flap, they're usually cut, and this becomes the third angiosome. And it usually is random pattern blood supply compared to the perforator pattern of the skin over the upper pectoral muscle. So 1 or 2 centimeters or up to 3 centimeters can be extended into the rectus sheath, but make sure you raise the rectus sheath along with the flap. And this picture shows the undersurface of the flap where you can see the pedicle coursing through the fascia. Now, it's always useful to divide the lateral and medial pectoral nerves, because if you divide the lateral and medial pectoral nerves, the bulk of the muscle will will shrink, and the muscle will atrophy quicker. So you don't have the unsightly bump over the clavicle, or the bulk in the oral cavity might reduce after some time. So it is always better to identify the medial and lateral pectoral nerves and divide them before taking the pectoralis major into the site of the defect. So you can either have a small pectoral skin paddle, or you can have a large pectoralis major skin paddle. It just gives you a lot of options and choices for closing defects in the cheek. So this is
I
an
agree for
example.
anterior.
A patient who has a segmental mandibulectomy, who has a tumor involving the skin. The skin, the mandible, and the buccal mucosa have been excised, and a bipedal pectoralis major flap has been used to close this defect. Now, the bipedal pectoralis major has the same sort of if you're considering a free flap, but if the muscle is not too thick and the skin is not too thick in the pectoralis territory, the deepthalizing and folding of the pectoralis does not add to unsightly bulk in the patient. So again, depending upon the habitus, you can decide what flap you want to do. But in patients who don't have too thick a muscle and too thick skin paddle, the intervening segment of skin can be deepthalized, and the skin paddle can be folded onto itself to close both the cheek defect as well as the skin defect. And it's always good to inverse plan the pectoralis major. So you can use glove paper or any paper that you want, or even a piece of gauze, and you can mark it from the midpoint of the clavicle to the defect. You can draw the defect out and then use the template to mark the skin paddle on the chest. Now, the skin paddle does not need to be oriented only vertically. It can be oriented horizontally or along a diagonal also, so it doesn't really matter. But as long as you have enough muscle capture on the skin paddle will work. So you've got to be very careful that you palpate the muscle always prior to raising a skin paddle, so that at least 3/4 of your skin paddle has adequate muscle capture. So this is a very large pectoralis major. Harvest is to close the cheek defect as well as the buccal mucosal defect. And unfortunately, in some cases, because the skin paddle is very large, we end up with skin grafting the donor site and reinforcing that with a piece of sponge. So this is how much of the skin that you can raise and the size of the defect that can be reliably closed with the pectoralis major flap. And this is how the flap looks inside the oral cavity. Now, the forehead flap is a flap that was used very commonly previously, prior to in the 90s probably, and prior to the advent of more robust flaps. The forehead flap is based on the anterior branch of the superficial temporal artery. And it is good because it is hairless, because you start harvesting the flap from just below the hairline. And the distal vascularity of the flap is also good. So a lot of people were doing standard foreheads, because there is a standard forehead and then there are midline forehead flaps. So the standard forehead flap can also be used if you are thinking of reconstructing a cheek defect, especially in patients who don't have a pectoralis major flap intact, or if they don't have any other option available, then a forehead flap can be used. Now, the forehead flap, after being raised, can be tunneled under the skin of the zygoma, and then you can bipaddle it and suture it to close the defect. The only problem with the standard forehead flap is that the donor site has to be grafted, and this looks unsightly. A lot of people tell you that you can include the brow because you have to remove one aesthetic unit so that you can replace an aesthetic unit like that. But I found that never have done that before in the foreheads that I've raised. Usually stay just above the eyebrows, and then you have to take care of the supratrochlear and supraorbital vessels. The plane of elevation is just above the periosteum of the forehead, because the periosteum is the base where the skin graft is taken, and you will have to include the frontalis muscle in the flap as well. When you're raising the flap from distal to proximal, that is from the opposite forehead to the pedicle, you will encounter the temporalis muscle, which can be left back on the patient. And the plane, as I mentioned, is just above the periosteum of the frontal bone. Now, this is a flap, like I mentioned, that should be kept as last reserve because the donor site is quite unsightly. Now, the other advantage of or another way of doing this forehead flap was tunneled. So there was no division of pedicle, or there was no need to do anything more. But here in this patient, what we had done was we had inset the forehead flap into the defect. And then after a period of 6 weeks, we used the remaining part of the forehead flaps after dividing the pedicle, because the vascularity was obtained from this local tissue here, and we folded it to reconstruct the lip defect. So, if you give enough time for these pedicle flaps to get their blood supply from their respective inset sites, then you can divide the pedicle, use the extra length of the forehead flap to refashion the lip or to refashion the defect of the commissure. Now, cheek defects are quite simple. Pectoralis major is the obvious choice. I can show you some pictures of supraclavicular, which can also be used for cheek defects. DP flap, as I mentioned, sometimes the distal vascularity is a problem. And forehead flaps you leave till the last, as a last resource flap. Don't try and do it before that. The lip reconstruction is a topic by itself. I mean, if the organizers wish, I have a huge presentation on lip reconstruction with different types of flaps. But this is just principalizing. This is one slide to show you what flaps that we can do. And the commonest defects that we have are the defects of the lower lip. And more than 1/3 lower lip defects are not amenable to primary closure. Either if you do a V or a W, it doesn't matter, but it doesn't close. And what you do is you try to borrow from the upper lip, or you try and recruit tissue from the cheek. So if you have a lateral defect in the lower lip, you can do an Abbé flap. If there's a commissure defect, an Aslander is fine. If you want to recruit from the cheek, if you have a very large defect, that is more than 2/3 of the defect is lost, of the lip is lost, you can either try a carapandic from both sides, a Webster Bernard from both sides, or a Gillies fan flap to close the defect. But in most of our cases, the defects are usually contiguous with cheek defects or mucosal defects on the inside. So it is quite difficult for us to use any of these flaps in oncological cases, especially in our types of oncological cases. In my book, the ideal flap to reconstruct the lip is a radial forearm flap with a palmaris sling. The reason being, if the commissure is also involved, the palmaris helps to reconstruct the commissure competence. So the patient will end up with a competent commissure. He has skin in the vestibule of the lip on the inside, and outside the skin of the mentum is closed by the radial forearm skin. So the ideal flap to use is a radial forearm with palmaris sling. And this also helps to maintain, the sling also helps to maintain the vertical height of the lower lip. But in cases where you don't have radial forearm, or the patient is not a good candidate, he's got multiple surgeries or comorbidities, or if it's a redo procedure, you can do an inferiorly based nasolabial flap for lower lip defects. Now, the advantage of doing a lower nasolabial flap is that part of the flap can also be used to augment the commissure. That is, the base of the flap goes into the commissure, and this creates a small microstoma and probably prevents leak of food from this commissure here. The only issue is that because you don't have a competent sling, or you don't have palmaris, or you don't have muscles that are in continuity, the nasolabial might be at a slight lower level compared to the rest of the lip. But you can always try to feed more tissue into the lip and less tissue into the vestibule. But these patients in the end always end up with an effaced vestibule and some amount of lip incompetence. So nasolabial flap is an ideal flap for a lower lip reconstruction, provided other options are not available, and this is a good pediatric option. Sometimes you can use bilateral nasolabial flaps if the whole of the total lip is has to be removed, and this probably gives you some amount of bulk, And the patient, by overcompensating with the upper lip and jaw movements, can close the mouth. And this is another way of using the nasolabials for lip closure, for lip reconstruction. When you come to oral cavity reconstruction, there's a lot of options available to reconstruct the tongue if you're looking at pedicle options and local tissue options. One of the commonly used option is the submental flap. Now, the submental flap is based on the skin of the mentum and just below the mental region, and it is perfused by the submental artery, which is a branch of the facial artery. Now, the submental artery and its vein traverses the upper neck between the mandible and the submandibular gland. They course anteriorly towards the digastric muscle. They pierce the anterior belly of digastric muscle and supply perforators to the skin. Now, you have to be very careful that when you raise this flap, the anterior belly of digastric has to be incorporated into this flap. Otherwise, the skin perfusion is lost. And you also have to be very careful not to indiscriminately clip all the veins that you see, because venous congestion is a common problem with this flap. So usually it is ideal where there is lax, hairless skin. So in women, it's quite okay. The size of the flap that we obtain is again depends upon the skin laxity. If you don't, this area is a bad area to try and skin graft or close with another flap. So the maximum lax skin that is available you can use to close a defect. The problem here is that a lot of people have complained that you have to take a lot of fatty tissue when you raise this flap. But there have been several authors who have been able to remove the flap and carefully preserve the submental artery and vein and perfuse the flap still. So in the node positive neck or in the floor of mouth malignancy, you probably may not do it. But if it's an N0 neck and it's a early tongue primary or a lateral tongue tumor, then it's probably safe to use. And there are two ways of raising the flap. You can either have anterograde blood flow, which is the standard submental flap, or you can have a retrograde blood flow through the upper end of the facial artery, which is a reverse submental flap. So this is a submental flap that has been elevated. It has to be tunneled through the floor of mouth. Make sure that the venous supply isn't compromised, and it can be inset into the defect. And you can still, by careful dissection, remove as much fat as possible from level 1A and 1B before using this flap in the oral cavity. It does get problematic if it's in a male patient because they grow a lot of hair. If the patient is undergoing radiation after this flap, the radiation usually takes care of the hair problems. Otherwise, it's a difficult problem for which there is no real permanent solution for the patient. Now, there are, as I mentioned to you, there are reverse submental flaps. So the normal submental flap is perfused by the direct flow from the facial artery into the submental vessels, and the facial artery is connected to the external carotid. Now, if you ligate the facial artery from the carotid end, and if you have intact superior labial and inferior labial arteries, through cross circulation, the upper stump of the facial artery can still reliably perfuse the flap. So by using the reverse submental flap based on the distal stump of the facial artery, the reach of the submental flap can be increased. So the submental flap can reach areas like the palate, the retromolar trigone, and different areas. And you can also use an adiposofacial submental flap without the skin by taking just the subcutaneous tissue and the anterior belly of digastric. But you must remember that in areas of mobile mucosa in the oral cavity, do not use adiposofacial flaps because they will again mucosalize and heal by secondary intention, causing scarring, and patient might end up with trismus. And there have been some people who have actually taken the inferior part of the mandible also based on the perforator which supplies. So when you trace the submental artery forward, usually there's a branch which perforates the mentum where the two halves of the mandible meet. So people have actually taken part of the mandible, the inferior part of the mandible, to reconstruct the maxilla or to reconstruct adjacent areas of the mandible. I have never done it, but these are some of the options, the osteomusculocutaneous options of the submental flap which people have used. So the standard submental is probably a safer bet, and make sure that the patient is node negative before you take the standard submental flap. Now, this is a flap that people don't do that much. This is an infrahyoid flap. This is based on the perforating branches from the superior thyroid system. So you can see here that there are veins. You can see here the superior thyroid artery. The superior thyroid artery obviously supplies the larynx, the thyroid gland, and also sends perforating branches to the strap muscles. So when this flap is raised, this is a skin flap with the underlying strap muscles and the perforating branches to the skin flap. And you have to ligate all the other branches. That is the cricothyroid branch, the branch to the thyroid gland, and the laryngeal branch also has to be ligated. And the veins should not be disturbed. They can either enter the facial vein or the internal jugular vein. The veins should not be disturbed. And this is a very reliable flap otherwise. The good thing about this flap is it's hairless skin. There are no lymphatics there. But there are size constraints. You can only take how much you can pinch the skin in the anterior neck. You cannot skin graft this area or close it with any other technique. And the reach sometimes is a constraint. Floor of mouth is okay, and anterior two-third tongues are okay. And you close the neck incorporating a Z-plasty. So if you do a Z-plasty, you avoid the contracture in the neck. So this is also a very elegant flap to do for the oral cavity, and I like it for floor of mouth defects because it reaches the floor of mouth really very well. And not many people do it, and there are not too many descriptions also, but it is a very reliable flap. There are no issues with its vascularity. Now, the nasolabial flap we saw for lip reconstruction. The nasolabial flap is a very funny flap because the dermal vasculature in the face is so good that you can raise a flap without the constraints of raising a 1:1 or a 1:1.15 or 1:2 flap in other areas of the body. You can raise a flap 1:4, 1:5 in the face. So even if you don't have a reliable facial artery, it will still work as a random flap. But it's always better to have it in a patient where the facial artery is still preserved. And you can, in this patient, we needed to resurface release of SMF on one side. So again, how much you can close primarily, the scar line falls on the natural crease. And this is a young patient with not much of options otherwise, but I prefer to do it in older patients because the skin laxity also tends to hide the scar quite well. And again, in this patient, there's a defect of a marginal mandibulectomy and the undersurface of tongue. And we used an nasolabial flap here because he had quite white skin and it was quite lax. And we just sutured it to the defect here. Now, there is another way of raising the nasolabial flap. You can totally island the nasolabial flap. For example, you mark out the nasolabial flap on the face. You dissect out under the skin the entire facial artery and the facial vein all the way to its origin at the level of the digastric. Then you tunnel it into the oral cavity and then you close the defect. Now, otherwise, what you would have to do is you would have to deepithelize a portion of the nasolabial flap to tunnel it into the oral cavity. And then you will have to inset the flap along its entire course, meaning the patient has to have no teeth because the flap cannot cross teeth. So in this patient, you can very easily do an islanded nasolabial flap. And this flap again can be used for defects of the tongue and for the floor of mouth. So this is quite easy to do. It doesn't take too long. Does not involve microvascular anastomosis, and I prefer to do this for tongue defects when patient is dentate and the nasolabial is a good option. Now, the converse of this nasolabial is the facial artery musculomucosal or a FAM flap. So we're taking in the standard nasolabial, you take the nasolabial flap based on the facial artery and it's applied to the skin. In the FAM flap, we take the facial artery and the overlying mucosa with the buccinator muscle to resurface defects. So the FAM can either be a pedicle flam or it can be a FAM which is totally islanded. So you can make incisions on the buccal mucosa after Dopplering the course. The facial artery courses on the buccinator and goes to the upper lip, just under the upper lip there to form the angular artery. So the mucosa overlying this facial artery can be harvested along with the buccinator muscle, and you can either have it inferiorly based or superiorly based again. Usually we have the inferiorly and posteriorly based FAMs that we use, and these can be used for palatal defects or posterior tongue or tonsillar fossa defects if they are still left attached to the pedicle. So you can have a good reach in most instances with the FAM flap if you don't island it completely. But just like how the nasolabial has been islanded, you can island the FAM also. So you cut out the mucosa in the oral cavity, you follow the artery and the vein, and then you bring it out into the neck, and then you take it medial to the mandible into the oral cavity, and then you close defects in the oral cavity. Now, this flap has got a lot of advantages because you're taking moist, secreting mucosa. So, in tongue, when mucosa is taken, you're replacing it with mucosa again. This islanded fam has mostly been spoken of for tongue reconstruction, and it will have some amount of sensations also. But the problem is anything other than skin when placed in the mouth tends to contract a bit. So this mucosa might contract slightly after its inset and might slightly distort after its inset. So this is just the perfect opposite of the islanded nasolabial, where there you take the skin, here you take the mucosa, but the dissection principles up to its origin remain the same. Now, for medium-sized defects, all you need to do is to close the mucosal defect, close the floor of mouth defect, and provide some bulk for the lost tongue because the remnant tongue will function and take care of the problems that the patient has. But what is the issue with large or total glossectomies? So, large tongue reconstructions, you should consider certain special important things, special considerations. Bulk and volume replacement is very, very important because the only way that the patient is going to be able to speak to a certain extent or vocalize to a certain extent and swallow is when the flap has good palatal contact. So you have to overcorrect it because the flap will shrink over time or will shrink with radiation. So you always overcorrect it during the surgery. So you have to do bulk and volume replacement. You have to obliterate the dead spaces because if you leave space between the teeth and the flap, there is going to be accumulation of food and debris there, and patient has to manually clean that food and debris from there. You should get a good palatal contact. There should be a stable oral diaphragm, meaning the suprahyoid dead space should be obliterated, and it's very difficult to recreate an oral diaphragm with the pectoralis major. With the ALT, you can use the facial artery to reconstruct the oral diaphragm. But when you do a pec major for a total glossectomy, you have to make sure that there is enough muscle to obliterate the suprahyoid dead space. Like as I mentioned, the volume of the reconstructed tongue diminishes over time, and hence we have to overcorrect. And pec major is an excellent choice depending upon the habitus of the patient. Here you see the pec major inside the patient's mouth post radiation 6 months. Still there is bulk. The skin has been shed and desquamated because of the radiation, and then there's no hair. But the flap has good contact with the palate, and the patient was off feeding tube and was able to vocalize to some extent. Now, even if you have defects like total glossectomy or total laryngectomy, the pec major is still an excellent choice. Again, here the pec major was used to close the pharyngeal defect and also create a protuberant tongue so that the patient does not have any dead spaces where the debris can collect. So, well planned, well executed pectoralis major is an excellent choice, even if you have total glossectomy with a total pharyngectomy and laryngectomy. If you have palatal defects, you have a few options of local flaps. One of them is the forehead flap, but you reserve it unless no other flap is available. The temporalis muscle is a good flap. Now, you must remember that the temporalis muscle used here draws its blood supply from the deep temporal arteries, which are a branch of the internal maxillary artery. So you've got to be very careful when you're working on the underside of the muscle, especially towards the zygoma. And the muscle has to be separated well from the fascia that invests it over the zygoma before it can be mobilized, and then it is transferred into the oral cavity. Now, this muscle will take some time to mucosalize, but it does mucosalize in a couple of weeks, and it can cover moderate to small to moderate sized defects. And you can even use bilateral temporalis flaps if you want to cover a total defect which is spanning from one middle side to the other. but trismus can be a problem if you manipulate too much, and the distal vascularity also of the temporalis can be a problem. So try to trim off the muscle which seems avascular or till you see good bleeding before you insert this flap into the defect. For small defects, for palatal and buccal defects, the buccal pad of fat pad is quite good. Now, the buccal fat pad is not the same in all patients. Some patients have a large buccal fat pad. Thin patients don't have a very large buccal fat pad. This flap derives its blood supply from the buccal artery, and you got to be it's very tenuous blood supply. It's not very robust blood supply. So don't try to separate the fat globules too much. Don't try to space out the fat globules to cover the defect. It has to be in a bunch. It has to have some cohesion. Otherwise, the vascularity of the buccal fat will go. So this is again useful for small defects of the posterior oral cavity, like the palate or the retromolar tricone area. Now, cervical skin defects can arise from doing neck dissections for large nodes, or when you're trying to remove a plate, or when the plate is exposed after mandibular reconstruction. Now, one of the common flaps that we use for the reconstruction of the cervical skin is the deltopectoral flap. Now, I mentioned to you earlier that there is a concept of angiosome that we all have to understand, and what the angiosome means to the flap. So usually the angiosome is a territory of skin which is being supplied by a particular perforator. Now, when Taylor did his seminal work on perfusion of various skin territories in the body, they found out that if you raise a flap which has angiosomes A, B, and C, angiosome A can reliably perfuse angiosome B, even if the initial supply to the angiosome B has been disrupted, because there are a lot of choke vessels or interconnecting vessels between the two angiosomes. But you cannot take the skin supplied by angiosome C, because the pressure to drive the blood across angiosome B to angiosome C does not exist unless you delay the flap. So you can capture reliably two angiosome territories if the proximal angiosome is preserved. And that's where the deltopectoral flap, the understanding of the deltopectoral flap is very important. The deltopectoral flap is the skin on the anterior chest. It is a skin overlying the pectoralis major muscle. The first angiosome or the primary supply, it's got three angiosomes, and the first angiosome or the primary supply is the intercostal perforators, usually the second and third because they are the biggest. They supply the skin over the first angiosome territory. Now, as you approach the deltopectoral groove, the second angiosome begins, and this is usually perfused by a branch from the thoracoacromial artery, perforating branch from the pectoralis major muscle. If you go beyond the deltopectoral groove and beyond the cephalic vein, you go into the territory of the deltoid muscle, where the flap skin is supplied by the deltoid branch of the thoracoacromial and the anterior circumflex humeral artery and its branches. So you can reliably take skin up to the deltopectoral groove. If you want to take skin beyond that, you have to delay the flap. So the concept of delay is that you raise the entire flap and you leave the flap without inserting it into the defect, meaning you disrupt the zone 2, zone 3 perforators, and then you leave the flap on the chest as it is. What happens, there are a lot of physiological mechanisms which then occur, which open the choke vessels between the second and third angiosome, and the vascularity of the most distant angiosomes becomes more reliable. So the usually delay period, you raise the flap and you wait for a period of 2 to 3 weeks. Some people wait longer. But at the end of 2 to 3 weeks, you can check for the distal vascularity of the flap. And if the flap bleeds well, you can transfer it into the defect. So you might have to do a two-staged transfer if the reach of the deltopectoral is quite high in the face or in the ear or something like that. Otherwise, if it's into the cervical neck or if it's for the pharynx, then you can reliably take skin up to the deltopectoral groove. And when you raise a flap, do not violate the territory within 2 centimeters of the sternal edge, because that's where the intercostal perforators enter into the skin. So here is a patient who had a defect in the cervical skin here following nodal excision. And we have taken the deltopectoral flap based on the second and third intercostal perforators, and we have inserted. Now, what happens after we insert the flap? You have to insert the flap and as wide an area as possible. Don't make your inset into a very narrow area. It's okay if you enlarge the size of the defect, because after some time you will have to divide the pedicle. The patient cannot walk around with an intact pedicle like this. The pedicle has to be divided after a period of 4 to 6 weeks. By then, the skin would have derived its blood supply from the recipient site. So you have to inset the flap in as wide an area as possible so that you can get some capture of vascularity from the local tissue area. Otherwise, you can de-epithelize the skin, tunnel it under the skin, and then go into the defect. That is another option. But in most cases, what I would do is insert the flap as wide as possible into the defect, and then divide the pedicle after a period of 4 to 6 weeks, and then reinsert the inferior part of the flap into the defect so that the vascularity of the flap is maintained. So for cervical skin defects, the deltopectoral flap is a good option. Again, this is the picture that I showed earlier. This is another patient who had a pharyngeal fistula following a laryngectomy. And this patient needed skin cover as well as mucosal cover. So I used a pectoralis major to do the mucosal cover inside, and the muscle was skin grafted to cover the skin defect outside. So even pectoralis major can be used for closing cervical skin defects. The supraclavicular flap is another flap that you can use to close cervical skin defects. It doesn't have the problems of distal necrosis as much as that of the deltopectoral flap, and it can be quite reliable and closed primarily. I will talk to you about the anatomy and the limitations of the supraclavicular, but it's a more recent flap that has been described, and it's becoming quite popular for skin defect closure, for oral cavity closures, and for pharyngeal closure. So supraclavicular flap is another useful flap that can be used. Coming to pharynx reconstruction, as I mentioned, for pharynx, you need to reconstruct a conduit. And this is usually, in a pedicle flap, is usually a skin line conduit. And we have two options which are currently commonly used. One is the pectoralis major and the other is the supraclavicular flap. Now, the supraclavicular flap is uh, a flap which is perfused by the supraclavicular artery, which is a branch of the transverse cervical artery. Now, the distal end of the flap can go up to the deltoid insertion. Should not go beyond that, because beyond that, the skin is perfused by the posterior circumflex humeral artery. So you can go up to the deltoid insertion quite reliably without having to delay this flap. The origin of the perforator is in a triangle, which is from the SCM, external jugular vein, and the clavicle. The skin is relatively hairless, can be closed primarily, and you don't have the problems of bulk as that you have with the pectoralis major. So this is the supraclavicular flap taken for a pharyngeal defect, and the tubing of the flap, and it's quite thin and nice, so you can close the cervical skin after that, and it's relatively hairless compared to the other flaps. So this is a good flap for pharynx, for cervical skin, and closure of some oral cavity or cheek defects. But keep in mind, don't go beyond the insertion of the deltoid, because after that, the skin supply is totally random. This is another patient. See how thin the supraclavicular flap is. And it's quite easy to tube it, and there is not too much of bulk. And to transfer it into the neck, you can de-epithelize the proximal portion of the flap and then tunnel it into the neck. And this takes it to the side. Or you can slit the neck, de-epithelize a portion, close the neck back on the de-epithelized portion, and then take the flap to the intended recipient site. The problem with the pectoralis major is that it is very useful. It has been the gold standard for pharyngeal reconstruction as a pedicle flap for a long time. But in certain individuals who are bulky, it is quite difficult to tube the flap, especially when it's a total pharyngeal reconstruction. Remember, you need at least 8 to 10 centimeters width of flap if you want to do make a tube of the pharynx. And if it's a very thick individual, it's very difficult to tube the flap, even if you take 10 centimeters of skin. And even after tubing, the neck closure becomes a problem. So you have to skin graft the neck. So the pectoralis major is another good option, especially if the patient is thin and if the patient's habitus is small. But keep in mind, if you're doing it on a bigger patient, you have to be prepared to skin graft the neck site. So the PMMC has got a larger skin island, obviously, than the supraclavicular if you're considering pharyngeal reconstruction. It's got robust muscle to add to vascularity. The data is available that in a salvage laryngectomy, when the PMMC is used as a skin and muscle flap, there is a reduction in the fistula rates. Sometimes the bulk of skin and muscle may make tubing difficult, and in high defects, the problem is there's always a pull of the flap in these pedicle flaps. In the supraclavicular, there's not much pull, but in a pectoralis major, because of the bulk of the flap, there can be a pull on the flap with suture dehiscence. So you've got to raise a very long and wide flap so that the inset is supple and there is no drag on the suture line in the pectoralis major. Supraclavicular is a more recent description. It's easier to tube. It lacks muscle, unfortunately, to add to vascularity. And we don't have data to show that it prevents fistula rates in the salvage setting as compared to the pectoralis major. A quick run through on eyelid reconstruction. In an upper eyelid reconstruction, the reconstruction, again, eyelid reconstruction, I have a separate talk on it. You have to break it down into anterior lamellar, posterior lamellar reconstructions which involve the tarsal plate, reconstructions which are for the upper lid, the lower lid. So there are different types of eyelid reconstructions. This is a Cutler beard flap, which is a tarsoconjunctival flap taken from the lower lid, suture to the upper lid and left intact. And after a period of 4 to 6 weeks, it's again divided so that the patient is able to open the eye and the lid margin is inverted and sutured. So this is another, I just put this because I had pictures. So eyelid reconstruction also, local flaps are much better. I don't think there are any indications for a free flap in an eyelid reconstruction. There's either, grafts that you can use, composite grafts or free grafts, or you can do local tissue transfers like Cutler beard or Hughes flap or a Trippier flap reconstruction. But this is one of the photos that I had of a Cutler beard flap. And for some other lower lid defects, you can do a mustardase, which is again a type of facial skin rotation flap. So you can rotate the skin of the face and then close the lower eyelid quite easily. Then for medial canthal defects, these are common after doing a maxillectomy, especially when the patient has been radiated. Again, you can plan a glabellar flap in these patients, or you can plan a Limburg flap and close these defects quite reliably with good vascularity also. Now, nasal reconstruction, there are a lot of difficulties with the nomenclature of these flaps. So if you look at the flaps that are supplied by the supratrochlear and the supraorbital arteries, usually it's a supratrochlear artery which is that we use to capture for these flaps. So you have a median forehead flap, you can have a paramedian forehead flap, or you can have a midline forehead flap. And for dorsal defects such as these, you can use a template to mark the defect and then use the template to mark the flap that you want to raise, and raise the flap and insert it into the defect and then divide the pedicle after a period of 4 to 6 weeks. And for nasal dorsal defects like this, the paramedian forehead flap is quite useful to resurface the skin defect. More complex defects, you might need to do a stage reconstruction with free flaps and cartilaginous grafts. But for dorsal defects, the paramedian forehead is quite useful to resurface skin defects. Now, the pedicle bone flaps, there have been a lot of pedicle bone flaps that have been described: skull with temporalis, rib with pectoralis major, scapula with trapezius, rib with serratus anterior, clavicle with sternomastoid, sternum with pectoralis major, and more recently, the osteomuscular dorsal scapular flap. But they're all far from ideal. They have limited bone stock, they have limited bone length, they have limited reach, and they have poor vascularity. So we don't have that many good options for pedicle bone flaps as we do for soft tissue pedicle flaps. So the sternocleidomastoid muscle, as you know, has a clavicular attachment and a sternal attachment. So based on the clavicular attachment, you can harvest the clavicle still attached to the muscle, and this can be used to reconstruct the mandible. But again, the vascularity is suspect and tenuous, and I'm not sure if it will withstand radiation, and it might undergo osteoidal necrosis also. So this is a very old photograph, and this is one of the options that we have, but I wouldn't recommend it for most patients where other options are available. The pectoralis major with the rib, you know that the pectoralis is attached to the fifth rib, usually fifth or sixth rib. Again, very tenuous attachments. You can use the rib, but the rib is not as rigid as that of the bone. So you might not be able to plate the rib when you put it in the defect, and you might have to use wires, making it an unstable fixation. Again, I'm not sure if this will, resist radiation or long-term survival, but these are options that have been described in patients who don't have other options for pedicle bone flaps. The pectoralis major with sternum is something that probably makes a lot more sense because the pectoralis has got quite firm attachment with the outer table of the body of the sternum. And basically what you do is you divide the attachments with the clavicle, you divide the attachments with the rib, you preserve the attachment of the pectoralis major with the sternum, and then you can use it as a bone flap. And because it's a sternum, you can green stick it, you can corticotomize the bone, and you can use a rigid fixation also. Here you can see that this is a pectoralis muscle, this is a skin parallel that is going to go over the muscle and plate to close the mucosal defect, and then the plate also. So this is probably a more reliable flap compared to the rib and the sternum master with clavicle. And the outer table of sternum is quite vascular, and when you see the bleeding after you raise the flap, the bleeding is quite good. The only problem is the skin over the sternum sometimes is difficult to close, and sometimes you might have to raise the contralateral pec major to form the muscle bulk and skin graft that area, because that area the skin is quite tight and might prove difficult to close. This is a long-term result of a patient who's got a pec major with the sternum. This is a very recent description, not too recent, but 10 years ago. This is the osteomuscular dorsal scapular flap. So we take the medial border of the scapula where the rhomboideus muscles are attached, and there is an artery called the dorsal scapular artery, which is a branch of the subclavian artery. Now, this dorsal scapular artery runs, parallel to the medial border of the scapular bone, and it gives perforating branches to the bone and to the rhomboideus muscle. So you can take the medial border of the scapula along with some of the rhomboideus muscle to preserve the blood supply. Trace the origin of the dorsal scapular artery, tunnel it under the lower trapezius. I have done this in the cadaver twice, and I found that the reach is really good and the bone stock is really adequate, and it can very easily reach up to the midline of the mandible if you tunnel it under the trapezius. The only problem is you've got to be very careful. You have to divide the trapezius to expose the bone in the first place, and you have to be very careful about the spinal accessory nerve that you don't damage it when you're tunneling the middle border of the scapula into the defect. So in summary, if you have a tongue defect, nasolabial, fam flap, submental flap, infrahyoid flap are okay for medium to small defects. If you have a larger defect, a pectoralis major might be useful. If you have a cheek defect, pectoralis major, a DP flap, supraclavicular flap are probably common options. Forehead would be the last option that I would consider. If you have a skin defect, local skin flaps like the Limburg or a bilobe flap, or if the skin defect is slightly larger, you can use a cervicofacial advancement flap. If the skin defect is larger, or if it is involving both the mucosal and the skin aspects, then you can think of pectoralis major flap. The other flaps for skin include the DP, the supraclavicular, and in extreme cases, the forehead flap. And for pharynx, the pectoralis major, supraclavicular, and the DP flap are good options for pharyngeal closures. So in conclusion, all the flaps that I mentioned to you are standard flaps. There's nothing new about them. The harvest techniques have been well described. There are potentials to extend the scope, by considering it for different types of defects, different types of insets, planning of the flaps. There can be modifications to all of that to extend their scope. Don't overdo pedicle flaps because distal vascularity can be a problem. There can be a problem with reach, and usually you should always have a plan B. If your if your pedicle flap does not work, then you're left with very few salvage options. So don't overdo, and always try to document, audit, and improve your outcomes with flaps. And I'd like to end this talk by putting something which Stellenmarin had written in their book, their most recent book. And Arnold Moran had said that first create no harm. In the local situation, work with your colleagues and do not compete because the only loser will be the patient. Audit and believe your results, and finally be holistic and ask whether what you plan for a particular patient would be what you would do for a relative. So we all have to work together to try and understand what we can do for the patient, and we should never cut corners, especially when it comes to reconstruction, because we have to do for the patient what we would do for a family member or for a relative, and this would make sure that we end up being good head and neck surgeons and good reconstructive surgeons. Thank you very much for your time.
So thank you, sir. Thank you so much for the presentation, sir. There are some few questions in the chat. Would you be able to take the questions now, sir?
Yeah, I can.
Yeah. Sir, question from Suresh Agarwal. Is the submental flap not oncologically inferior because it drains 1 year lymph nodes?
Is it oncologically inferior because it drains 1A?
Yes, sir.
Yeah, so see, like I said, the submental flap is good in cases which are N0. And there's a large series which has been published from RCC Trivandrum, where they did it on a lot of tongue patients, and they found that there was no increase in nodal recurrences, or there's no increase in nodal positivity or nodal relapse. So it is a well-established flap, provided you know how to dissect off the fat from the flap. So people have been able to dissect off the flap, the fat and the lymphatics from the flap before harvesting the flap. So there is an eternal debate whether it's oncologically safe, but for lateral tongue defects in an N0 neck for early tongue tumors, I think its oncological safety is quite okay.
Okay, thank you, sir. Sir, the next question is that what is the superior extent of the reach of PMMC and lattice mucosa, especially when they were doing reconstruction of ITF in ITF clearance cases?
So if you mark the flap over the rectus sheath and if you raise it, the flap will reach. It all depends on how you inverse plan the flap. You have to plan the flap in such a way that you have to use the most, distal edge of your defect has to be taken into account when you plan the pectoralis major. So it will reach the buccal mucosa, but it's very difficult for it to stay in place for palate and fill the ITF. So that part of the flap might end up being the random part of the pectoralis major that we are harvesting. So again, it depends upon the length of the neck, how much. If the patient's got short neck, then there'll be more flap reach. If the patient's got a very large pec major and you're able to take the inferior marking of the pectoralis major to the rectus sheath, then it will reach. But I wouldn't do a pectoralis major beyond the buccal, for beyond buccal mucosa defects. I wouldn't go to the ITF with the pectoralis major because I've seen it dehisce from the superior suture line.
Okay, sir. Thank you, sir. So the next question is from Dr. Ratan Shetty. He's asking about the tensile flap.
The tensile flap.
Yes, sir.
And for what context?
He was just asking it. I think it's for the orbital reconstruction, I think, sir. Tensile flap.
So tensile flap is basically it's a bipedical flap where you transfer skin from the upper eyelid to the lower eyelid. Is that what he's asking for?
He doesn't have a specific question. He was asking during the orbital reconstruction, which you were describing then.
Yeah, so tensile is basically a skin line flap where you can use it from. See, it's difficult. I can send, if you can ask him to ping me his email ID. I can send him some photos.
Yeah, sure, sir.
Just give him my number. So if he can send me his email ID, I can send him some pictures of how a tensile flap is done for eyelid reconstruction.
Okay, sir, sure. Sir, and question from Dr. Abhijit Singh. He's asking your opinion on occipital flaps.
I have never done an occipital flap. I know Tata does the scalp flap, which is basically taking scalp subcutaneous based on the superficial temporal artery into the scalp. But I haven't done occipital flaps, so I wouldn't know. I wouldn't have any experience on occipital flaps.
Okay, sir. Question from Dr. Achut. While doing a bilateral nasolabial flap, when the flap goes into oral cavity, both sides become very congested, it seems. Do you have any tips to prevent that or any procedures to overcome that difficulty?
if you do bilateral nasolabial, if it gets congested, probably your inset is very tight. The inset has to be lax. If you try to pull and see, basically the commonest causes of venous congestion are either too tight a closure, or the tunnel is too tight, or the flap base is very narrow. So you try to make the base of the flap slightly wider. Try to keep your inset and your suturing supple, and try to keep the tunnel a bit more lax. If you try these things, then the usually the flap congestion will. And then again, post-op, see, all of these pedicle flaps, some of them will have some amount of congestion for some point of time. Then usually the congestion settles down. So try to keep the base of the flap wide, try to avoid too tight closures, and try to avoid tight tunnels. And this will usually tend to keep the flaps, from recongesting in the long term.
Okay, sir. Sir, the second question is, I couldn't understand the question, but the question is, in lower lip reconstruction, the use of bucket handle mucosa from upper lip for lower lip mammalian reconstruction.
Yeah, you can do. So you can do there is lot of lip switches which are available. So you can do a vermilion switch also. So you're talking only about reconstructing the mucosal aspect of the lower lip. That can be done in the bucket handle where it's pedicled on both sides. You're not dividing the pedicle. So if you want to reconstruct the vermilion or the mucosal aspect or part of the vestibule inside, you can use a bucket handle bilateral vermilion bilateral pedicle flap. It can be done, yes.
Okay, sir. And question from Dr. Shubhani Tyagi.
Yeah.
What is burrow triangle? I think many questions are there over the lip reconstruction. Like you said, we can do a separate, complete detailed webinar on lip.
Something which allows you to close it. So I'll have to talk about advancement flaps. See, if you have to talk about Burroughs triangles and they're all part of advancement flaps and how to avoid a dog ear. So in lip reconstruction, I'll be able to talk about Burroughs triangles and where to use Burroughs triangles, where in the base the Burroughs triangles are located, what should be the size. So I can do all that if we do a lip reconstruction talk.
Oh, okay, sir. Sure, sir. As of now, those are only the questions posed in the chat, sir. So this is the end of our session, sir. Sir, we thank you so much for giving us this opportunity, and we're looking forward to your next presentation on your next Wednesday.
Yeah. So please ask the gentleman, the doctor who wanted about Tenzel, so I can send him the.
Yes, sir. I will send him his number right now in the chat.
No, can you give him my number and ask him to send me his email ID so that I can send him some material?
Yes, sir, sure. That's what I'll do now, sir.
Yeah.
Yes, sir.
I can do that.
Yes, sir. Right now I'm putting it in the chat, or I can just announce it in this form also.
You can announce it in this forum so that they have my WhatsApp number.
Yes,
and if
sir.
any of their messages or questions, I can take them based on this presentation.
Sure, sir. For everyone, the number of Dr. Deepak sir is 98400 I repeat, 98400 I'll put that in the chat too.
Yeah, and see, eyelid reconstruction. I'm just going through the messages that people have put here. For eyelid reconstruction, see, there are different ways of looking at eyelid reconstruction. You have to think of what is the anatomy of the eyelid, what is the anterior lamella, what is the posterior lamella. When do you use free grafts? When do you use composite grafts? What are the sources of the grafts? What are the techniques to prevent ectropion? What are the techniques to preserve the eyelash margin? When can we borrow? So what is the marginal artery of the lower lid? Where is the marginal artery of the upper lid? When can we borrow skin from the upper lid to the lower lid? When can we borrow tarsoconjunctival tissue from the lids? So eyelid reconstruction is a very, very complicated topic. So that also can be made I haven't made a presentation, or I have few slides on it for other talks. I don't have a specific dedicated eyelid reconstruction talk. But if we can do eyelid reconstruction and lip reconstruction together, I think we can do 1 hour.
Okay, sir. Sure, sir. Sure.
And see, in eyelid reconstruction, we don't have to talk about the whole gamut of eyelid reconstruction. We just have to talk about what is relevant. That is practically that what you see. You either you see complete eyelid loss, or you see less than a third eyelid loss. So you need to know what is the pentagonal concept, and how do you first take stay sutures in the tarsus and then the muscle. So it is very basic concepts, but the pictures, I have only pictures because we don't do that many eyelid reconstructions at Amrita. So I can, if the people in the group want more eyelid reconstruction and lip reconstruction, we can do together. Uh, Together, I think that will be quite good.
Yes, sir. Sure. Definitely, sir.
Yeah.
Yes, sir.
Yeah.
As of now, there are many congratulatory messages, sir. And,
Yeah, no problem. If you have time, after the free flap, we can also plan after a week after that. If everybody is available, we can plan lip and eyelid reconstruction together in one talk.
Sure, definitely, sir. I'll plan that out, sir.
Yeah. So in that, when you're doing lip reconstruction, when you're talking about Karapanzik, or you're talking about Webster Bernard, there'll be a lot of things about Burroughs triangles and when do you take out wedge and all those things. I can talk about those things at that.
Okay, sure, sir. Sure, definitely, sir. We'll work it out.
Okay. Thank you so much.
Thank you, sir.
Thank you so much.